Hello, everyone, and welcome to a new CPH 290 lecture. Today, it's a great pleasure to have Travis to better understand and predict patient outcomes using real-world patient experiences. And today, he's going to talk about personalized oncology that balances the risks and benefits of treatment. Thank you so much, Travis, for joining us today. I really appreciate it. I know you're busy, and I'll hand it over to you.
Oh, thanks. Thanks so much, Ahmed. Thanks for inviting me. I'm really excited to be a part of this community and get to talk to you guys. Can you hear me?
Yeah, we can hear you perfectly.
Okay, great. Yep. So as Ahmed said, I'm Travis. I'm an oncologist, focuses on pancreatic cancer and other cancers of the GI tract here at UCSF. In my lab, I have a background in computational genomics, but I've been spending the last few years on a broader perspective in the electronic medical record, trying to understand how we can use this to improve patient lives. So just as some background into what I do as a clinician, and kind of the steps that a cancer patient will often go through. Cancer, it is a disease, but there are many different steps in the path a cancer patient takes. And that actually begins before the diagnosis process, where symptoms are developed, or even, before that, if there are predispositions or risks for development of cancer. Once a diagnosis is made, the first step is determining what the right goals for treatment are. And then at each point, really from week to week, we have new decisions that have to be made for patients. What is the best first therapy for a patient? Is the therapy working once we start? And then, eventually, in a lot of cases, therapy stops working. And once that's the case, we have to decide again, what is the best next line therapy? Should this person be on a clinical trial? And, eventually a very important decision to be made is further aggressive treatment beneficial for the goals of the patient? Or, or are we getting to the point of overtreatment where we're actually, betraying the Hippocratic Oath and doing more harm than benefit? And so at each of these stages, these are decisions that have to be made by a clinician with data that is presented to them about the patient in conjunction with the patient's goals and an understanding of what the patient wants and what they've been through. So in cancer, as with a lot of medicine, but I would argue that in cancer, it's worse than most other fields, is each of those clinical decisions has to incorporate data across lots of different modalities and across lots of different time points. And this is only accelerated as we understand more and more about the disease, and we have more and more options for things like targeted therapy and immunotherapy. Cancer is an evolutionary process. And so understanding not just where we're at now, but what has happened in the past is really critical for understanding the right treatment or right decision to make. And at this point, a lot of that is really driven by clinical judgment, maybe with some hints based on, retrospective data or clinical trials. And so combining all this data is obviously a very challenging task for clinicians, or really humans in general. So my research interest is, how do we use all this data that we collect in the real world to better inform care? One of the big challenges here is that cancer is an aggressive disease and requires very aggressive treatments. And because the cancer cells are only recently evolutionarily distinct from human cells, a lot of times our treatments are extremely toxic to the rest of the body. And so the balance of treating the cancer and getting effective treatment and keeping the patient well enough to continue and actually have a good quality of life, which is often our goal, is a tough balance that we constantly have to figure out as a clinician. And can we actually inform those treatment decisions better using real world data and machine learning techniques? So I'm going to try and cover a couple different topics today. One is injection of domain knowledge into real world data for improved modeling and understanding of treatment, kind of as a foundation for future predictive modeling work. And then I'll talk about some of the stuff we've been doing with language models. The focus today will be on the clinical utility and biases that can kind of come into play as we use language models in medicine. So as Ahmed mentioned, the data sets that I typically work in is cancer patients across the UC system, with UCSF being our primary focus, given that's where, that's where I work and do my clinic. This actually is a very, UC has 6 medical centers, 5 of which are designated as comprehensive cancer centers. And we see about 130 active cancer patients across this, which represents 20% of the cancer patients in California at any given point in time. California is one of the most diverse states in the country, so this actually represents a very good real-world data set to think about how we're treating cancer now in the real world across diverse population sets, not in specific clinical trial, highly selected patient populations. The data sets that we can use in this data often involve tabular data. So those are things like diagnoses codes, medications, hospital visits, genomic data, so clinical genomics that we collect for these patients to help inform their care, clinical notes, so this is unstructured text that we document the progress of the patient in the medical records for both the patient and other providers. And then, of course, imaging data, so radiographic images, which play an important role in cancer treatment. So one of my first projects when I got here as a fellow was trying to understand the treatment variation in real-world oncology. And this was driven by a realization I had when I was first starting in cancer. And that was that when I was a general medicine doctor, I just assumed that we have these protocols, we have these flow charts of what a patient should get given a specific disease and a specific line of therapy. I just thought that's what they get. And then when you start treating patients, you realize how infrequently you actually can give them standard of care for any number of reasons, and how many times you have to modify therapy for any number of causes, often due to the adverse events that a patient experiences. So while there's a book that says what you should do, very few patients actually get that what you should do. And that, if you want to create a model to predict whether a patient will benefit from treatment, understanding that variability is the first step. The challenge is, so let's see, what are we doing for time? I'll skip this slide just for a minute. So one of the challenges when we start to look at this in big data, so large data sets, is really understanding the specific trajectory of a patient can be challenging the larger the data set is and the more or the less manual that process is. And so this is a slide I've kind of created and used a few times to illustrate that. So if we go to kind of traditionally how we think about understanding observational data from clinical, from real world clinical experiences, typically we'll do something called chart review. So chart reviews, you'll have an expert look at individual cases and document specific information from each of those cases, where that expert is very well, has the expertise to pull that information out and has the time to do it. And that can lead to very accurate information that's very both sensitive and specific. So for example, if I'm interested in a very rare subspecialty of pancreas cancer, I can go try and pull a bunch of those charts, which may or may not have that disease, and then have someone review each of those charts to pull information out of it, such as whether it was a localized non-functioning neuroendocrine neoplasm of the pancreas, which maybe that's what I'm interested in, and then read the pathology note to get confirmation of that. The data set I typically work in are things like electronic medical records. In that case, often we have a lot less precision on what exactly the diagnosis is or the treatments are. And we also have a lot, there can be some missingness or errors in that, right? Not every person faithfully puts the information down in the medical record correctly. Often patients come from other systems like Kaiser or Sutter before they come to UCSF, so we can have missing data. And sometimes the specificity that I want as a clinician isn't necessarily the specificity that would be put in something like a diagnosis code. And so here I'm kind of trying to represent that with an image that is a little more blurry and has some pixels that are missing or different. And then you can get even worse, right? Insurance claim databases has even less precision in the information and can often have lots of missing data. So one approach that we can try to use to improve the information that we're using within each of these systems is to inject domain knowledge about what should be going on and what could be going on into each of these systems and develop algorithms to apply that to the data that we have available. So the idea here is take information from experts such as the NCCN, which tells us what protocols should be used at a given point, hemonc.org, which tells us, which is a oncologist curated database of what protocols are available, or ASCO, which is another one of these, and say, look, this is what could be happening. This is the realm of possibility. What is the most likely set of situations that could be going on given the medical data that we have available? Take that along with kind of the precision we would get from a focused single EMR extraction to at least get slightly better sensitivity, specificity, precision for each of these cases. And kind of transfer that information forward once you have it in one set to data sets where there's less and less precision. Of course, you can't squeeze milk from a stone, so to speak, but you can start to improve your understanding of your database by injecting some of this domain knowledge. So why is this so important in cancer? Well, real-world clinical data is complex and messy, and no more so than in cancer data. So this is an example of a real patient's chart where the left side demonstrates all the anti-neoplastic medications a patient has received. And the date, this is over their course of a few years, a number of years. And you see that we give lots of medications in combination therapies. And there are thousands, literally thousands of different ways we can give these combination chemotherapies. Some of these are approved and have been run through clinical trials. Others here at places like UCSF are investigational, right? We're testing whether or not this particular combination works for a set of patients. When we have real world data, we have to kind of understand that all this could be going on and how do we piece apart what the protocol or the goal of the therapy was. The other thing that I like to show with this slide is that there are a lot of inaccurate information. We like to think that each of our medical records really has gold truth in it, but there's a lot of inaccuracies in the medical data. So these are the diagnoses that were listed for this patient at some point during their chart. And that includes cervical cancer, colon cancer, ovarian cancer, pancreas cancer, and prostate cancer. And biologically, vanishingly few patients have both a prostate and an ovary. So at least one of these was inaccurate. So understanding what the right diagnosis is for this patient, given the treatments that they were given, could be helpful to better understand the cohorts that we would need to create in these real-world data sets. So what defines a patient's treatment history? Well, the treatment history can be the drug, surgical, and radiation interventions they've gotten. And our goal with this project was to define that based on a database of a comprehensive database of all the potential interventions that we provide for oncology patients that have been tested over the last 40 years of clinical trials. So I think what often people don't realize is that just because you know the drugs a patient was given does not mean you understand the protocol. So this is an example of a protocol and how we should give these drugs. These are 3 drugs, and this is how they were given, both the dose, which is listed there, and then what days we should give them and how often we should give them. These same 3 drugs can be given a number of different ways, and each of those are different. Those are different protocols. They've been tested in different situations, and they may have different outcomes. So it's understanding which protocol is important to understand the cohort, then you can create a predictive model to determine whether the outcome is something that you want is beneficial for the patient. So even if you knew the protocol, that doesn't mean you know the full treatment, because the regimens are often modified due to side effects, toxicities, or laboratory values. These modifications can be dose reductions, they can be scheduling delays, or they can even be changes in the way we schedule the therapies. And sometimes whole drugs are dropped or replaced. And this is where the art of medicine comes in. And that's why being an oncologist requires so much training. But for real world data, it's really important to understand these if we want to train models on them. So for this project, what we did is we leveraged an open resource called hemonc.org. We collaborated with them. This is an oncologist curated database of 5,000 regimens that we provide to patients. We took the information from each of these regimens and converted that into a format that we could then look at an individual patient's chart and create the maximum likelihood estimate at each point in time for which regimen a patient was on, and then use that to determine, given that regimen, what modifications were made to that regimen over the course of a patient's care. This is just a little schematic of how it worked. We tried to use the lowest common denominator that would be present in most of these observational databases that hospital systems have, and that includes the diagnosis codes and the drug information. We then combined that with hemonc.org and did this in a disease cognizant but not reliant way. So we allowed for an understanding of which protocols work with which diseases, but recognizing that a lot of off-label utilization of these protocols are possible. So there may be cross-utilization of these protocols across therapies, and use that as part of the fitting process. The model was a time series convolutional maximum likelihood estimate, which in the end gave you a diagnostic likelihood of the diagnosis for that patient, the identification of the protocols, the number of cycles a patient's got, and then deviations from standard of care protocol. This is kind of the output. I will save that. And I'll show you a couple use cases of how we're using this. So I'm, as an oncologist, my focus is pancreas cancer. It's projected to be the second leading cause of death in cancer-related deaths by 2030. And that's mostly driven by lack of advances in treatment. While I'm sure you've heard things like lung cancer, even prostate cancer, a lot of these have targeted agents based on our understanding of the biological mechanisms that drive these diseases. Pancreas cancer, we're still using standard cytotoxic chemotherapies that we've been using for the last 30 years. We've advanced in how we use them. We basically just try and use more and more, but we haven't found a way to really use the biology of what's driving pancreas cancer to help treat patients. So what we end up with is highly toxic, poorly efficacious, multi-drug chemotherapy regimens for this highly aggressive disease. Right now, there are two standard of care treatments. FOLFIRINOX is a 3-drug chemotherapy regimen, and gemcitabine Abraxane is a 2-drug chemotherapy regimen. Both of these seem to be equally efficacious. They're both highly toxic. And unfortunately, in patients, again, in patients where we're giving this highly toxic therapy, in the first one, retrospective and the original clinical trial shows about a third of patients derive no benefit for this, right? So we give this therapy in which people feel fatigued for weeks at a time, lots of nausea, can get long-term effects like peripheral neuropathy, and a third of patients have no benefit after doing this, and all we've done is waste time while their disease progresses. It's even potentially worse in gemcitabine Abraxane. It's a slightly more tolerable medication, but as much as maybe 50% of patients do not respond to this first-line therapy. And therefore, we are giving this therapy to patients for a month or two at a time, wasting time where they could maybe be on a clinical trial or getting the alternative. and we find out that this actually is not an effective treatment. So coming up with ways to make a prediction as to whether or not this will be beneficial for a patient would be highly clinically useful for decision making. So personalized medicine at this point in a lot of diseases like pancreas cancer and others is not driven by the biological mechanisms. And so this is an example of using the algorithm to understand what are the patient trajectories for this disease. And these are the treatments that a patient is getting over the last 10 years, where each color represents a different UC campus, and the width of each of these represents how many patients go along this trajectory. As you move left to right, we're talking about first, second, third line therapies. And as a clinician, this is really helpful for me to dive into this information and understand, how are we treating patients at UCSF, and how does that differ from how we're treating patients at UCSD? As a first step to understanding, if we see differences in outcomes, what would be the hypotheses for why these outcomes may be different? So my big takeaway from this as a clinician is the right side is, in the end, when there's no further therapy, and how many patients go directly from first line therapy to no further therapy. And that usually means that they're too sick, because this is metastatic. We do not cure metastatic pancreatic cancer. So patients that go directly from first-line therapy to no further therapy means that after they've progressed on first-line therapy, they are too sick to receive any other treatment. And that's why I'm so motivated to find better ways to predict what first-line therapy should be in these diseases. It gets even more complicated than this, and I love this slide, and I'm going to spend just a minute to describe it. So a basic assumption of pharmacology is that dose is correlated with efficacy and toxicity. Now, I would argue in a lot of our newer therapies, that is not always the case, especially for things like immunotherapy that have an intermediary of the immune system. But in chemotherapy, I think that's been very well kind of established. The more of the drug you give, the more efficacious it might be, but it also might be more toxic, recognizing that might be a non-linear relationship with both. However, in the clinical trials, they took very healthy patients, and most of those patients were able to get through the therapy that was provided. In the real world, we have sick patients with comorbidities, and we have to think about their quality of life and what they actually want to do, not just what the clinical trial dictates. This plot shows, for one drug in the 3 drug regimens, how many patients who started at 100% of the dose continued at 100% of the dose throughout the course of their treatment. So at each bar from left to right, we're looking at cycle 1, cycle 2, cycle 3, cycle 4, etc., along the treatment of this regimen, FOLFIRINOX. And so for just one of these drugs, if we look at the big bar on the left, which is the number of patients who started at 100% dose, you can see how quickly those patients whittle down to much less than 100% dose as we get through to cycle 6, cycle 7, cycle 8, where this starts to split up in how many patients get 80% of the dose, how many get 75% of the dose. And so if we're trying to make a prediction or train a model to understand whether or not this therapy will be efficacious, this is critical to understand that by the time we get to cycle 6, most of the patients are not receiving what we would call standard of care dosing. And that's not any fault of the patient or the clinician. That's because it's just a very toxic regimen that we can't give full dose of. So these are the kind of things that I'm really excited and I'm actually working with Ahmed on to build into models to understand how we can produce how we can predict efficacy and toxicity based on these trajectories. I'll skip some of this in the interest of time because I want to have lots of time for questions. But we're, again, working with other clinicians across our health system and UC, we're using these kind of descriptive statistics already to understand how we treat patients differently and how that might actually affect the outcomes we're seeing across different centers. So this is an example. One thing for patients who could be cured for pancreas cancer, that's only about 20 to 25% of patients who present. We give this regimen and we give surgery. But we don't know whether we should give the chemotherapy first or the surgery first. Places like UCLA love to do the surgery first and then do the chemotherapy. Where we at UCSF, I would say most of our surgeons prefer us to do the surgery, the chemotherapy first and then do the surgery. So looking at how different sites manage, did we do the chemotherapy first, which would be NAC here, that's neoadjuvant, versus adjuvant versus kind of mixed, where we did some chemotherapy, then surgery, can help us understand, well, first, did they get to completion with their chemotherapy? One thing that we're concerned about at UCSF is when we do the surgery first, the patients are often too sick and have a lot of complications to get through the chemotherapy afterwards. So our surgeons like to do the chemotherapy first. What we found looking across sites is UCLA does the adjuvant therapy because for some reason, they are able to complete adjuvant therapy better than us. Now, does that lead to better outcomes? Well, not necessarily at this time, but it does show like there's something they're doing during surgery or during the postoperative setting that helps them get through the chemotherapy afterwards that we at the UCSF group aren't doing, and allows us to explore, okay, what are the differences in the surgical and postoperative care that could lead to better tolerance of chemotherapy afterwards. I'll just briefly talk about, okay, now let's talk about outcomes. What can we learn from combining data across institutions? So obviously we increase our power and we increase the diversity of what people are getting in the clinical practices. So this is, again, just an understanding of the age distribution, and we can really get a better understanding of why people are choosing one therapy versus another in the first-line setting. And this changes across different institutions. So one application that we've done is for one of these regimens, gemcitabine Abraxane, in the clinical trial, it was tested at the regimen was give it every 3 out of 4 weeks. So you give it 3 weeks at a time, once every week, and then you give the patient a 1-week holiday. Even in the clinical trial, over 2/3 of patients required some amount of dose modifications, either due to neutropenia or other lab or clinical toxicities. So even in the clinical trial, they knew how toxic this regimen was. Since then, once you expand it to broader populations who might already have comorbidities or might be elderly, we've recognized those toxicities are even worse than the clinical trial showed. So a lot of physicians don't even try what was done in the clinical trial and do an alternative regimen that has never been tested in a randomized way called every other week. So instead of doing 3 weeks on, 1 week off, they just do every other week for this therapy. Again, that's giving 50% less chemotherapy, right? And so understanding what the effect of that is on efficacy is really important, because if there's no effect on efficacy, then we're giving patients 50% more chemotherapy than they need. If there is an effect, we should make sure that patients are aware of that and have a real discussion about that before just assuming that they're equivalent. So we did this retrospective analysis, and being able to use the whole UCs, we were able to do this analysis with about 4 times more patients than had ever been done before, because previous approaches were kind of retrospective chart review approaches. And that's what I'm showing here. And this is preliminary data, and isn't controlled at this point, but we found that there's non-inferiority in these two when you compare them. And the reason I'm excited about this is it's not controlled, but we are setting ourselves up for failure, because one would expect that sicker patients, older patients, patients with more comorbidities would be started on the regimen with less chemotherapy more often. So the null hypothesis might be that there would be a difference here. So I'm going to do a hard transition in the language models. I don't know how you guys normally work this, but now might be a good time to just take a quick break for thoughts or questions about that stuff, because we're going to talk about something completely different.
Any questions in the room on the first part? think one question I had was like regarding the difference between the way different institutions
Yeah.
handle yeah, the treatment regimens. Like to what extent do you think the things that explain the differences are just unobserved versus things that you can control for in this combined UC data? Because I think like it doesn't like if there's like a patient features that like true like very powerfully explain differences in treatment decisions, wouldn't this be like so obvious in the combined UC data? And like from your just like anecdotal experience, do you think that differences in the populations are like just hidden factors or social factors come into play that are
I actually don't think that's the case. I will tell you, it's not measurable, but it's causal. And
okay?
so, um, and this is more from, clinical experience than than anything that we can pull from the data. But despite having, hundreds and hundreds of patients, you have to realize that our oncology departments are relatively small, right? We have 5 providers here that provide um, that focus on pancreas cancer, and we're one of the largest institutions that does pancreas cancer, right? Um, and so those 5 providers were all taught by the same person who also works here, and surgeons
Mm,
are similar, right? Oh, sorry, let me think. Oh, one of them was taught elsewhere and then moved here, but probably gets a lot of their experience from this matriarch who, like, is head of the NCCN. She has a lot of experience, and I learned everything I know from her. And one other person, Andrew Coe, who also learned everything he knows from her. So, so there's a lot of like incestuous clinical learning that happens at institutions. Same thing
okay.
happens at UCLA. Same things happens with surgery versus medical oncology. So a lot of this is just um, shared learning that happens at institutions, and clinical practices based on shared experiences that we can start to learn from other institutions how they do it. And yes, we can. I think the first step is understanding there's a difference, but then we have to have communication to understand why are we doing things differently. So we bring this hypothesis, and I've done this a couple of times where I bring this to the UC Pancreas Consortium. I'm like, here's a difference we're seeing. And then the UCLA surgeons will tell us why they do it this way. And that starts a dialogue to start to understand why we might be seeing these differences. So and that might not be true across things. I think there are a lot of other reasons that we could be seeing differences across the UC, and things like, exactly right, like maybe not demographics, which is something we can see, but one thing, for example, is our footprint versus footprint of UCLA, and whether they do a lot of their care in the kind of satellite centers versus everything local, and how that relates to what their choices are for systemic. So there are a lot of these factors that relate to how things, geographic or patient population, that may be harder to capture. But I do think the descriptive statistics aren't necessarily to come up with a reason, but they are to help us understand how things are being done at different institutions, so we can have a dialogue about why. And then we can move towards, okay, if this is affecting outcomes, how do we test to see why it's affecting outcomes?
Okay. Other questions? Yeah, just like another quick question, which is more about like how to think about this problem. And I wonder if do you think the solution is like a policy solution, is like it's an operational problem that you kind of need to avoid the herd behavior of like how people approach care and like learn from others and just like have a more systematic process that's like data driven using retrospective data? Or do you think that the reason we are herding and learning is that there is no good biomarkers to inform treatment decisions, and we should actually try to find better inputs to the models or better inputs to our guidelines as opposed to looking at what we have already been doing with the existing data and trying to improve them over them?
Yeah, so I would say for most of these, the answer is definitely the latter, where there's no good existing data for the right approach, right? One would hope at places like UCLA and UCSF, if there were wide discrepancies and one had like very good evidence-based reason for doing it one way, that would be mitigated very quickly. So when we see discrepancies, it's because there's no good evidence-based answer, which is fine, right? If there were evidence-based answers for everything, we could just follow a rubric and we wouldn't need 6 years of experience. So I think it's much more about learning from the experiences of these differences, right? It's like, okay, given that there's no right answer, one person does it, one group does it one way based on, incestuous learning, one person does it another way based on incestuous learning. What are the outcomes in those different groups? Controlling for the confounding variables, and can we learn something from each other? Yeah.
I think we can proceed to the LLM part.
Okay. Yep. Yeah. And I'm not gonna I kind of picked just one thing we're doing with LLMs. But obviously this is a big topic that a lot of people are interested in. So as a clinician, I think that the big thing is LLMs are coming. What should we do about it? And of course, everyone here or a lot of people here are probably familiar and maybe using them in their research. We are starting to have them in clinic, and that is, again, just incredible to think about compared to where we were 2 years ago and how slowly medicine moves, right? So yes, of course, we're using it in coding and we're using it to create recipes, but you think about how long it takes for a drug to go from in someone's lab to clinical use, which is on the order of a decade to 15 years. And how quickly this is now potentially going to be used directly in patient-facing care and clinical decision support. The timeline has been tremendous. The concern with that is, with any new tool, there's a lot of unknowns regarding capabilities and risks. And especially with something that's potentially going to be implemented this rapidly, and with an FDA that still doesn't really know how to handle a lot of these things. Clinicians have to start to become aware of how to think about and how to use these tools. So I'm interested in it from a clinical perspective or from a research perspective, because there's a lot of dark matter in cancer care, both in outcomes and in features that we might be able to use language models to help fill in. So as I talked about, toxicity is a big thing in cancer therapy. A lot of those toxicities are patient reported, like how I'm feeling during the 2 weeks when I don't see you. And that can be very hard historically to understand, much less use as features for modeling whether or not a person's receiving benefit. So extraction from some of these the ground truth from documentation previously has been very fraught with challenges, even in the old kind of BERT days from like 2019. And so it's exciting to think about how language models can help expand what we think about as the variables when it comes to making a prediction about benefit for a patient. In clinical care, we have to find the balance between the efficiency and risk. So, there are lots of different things that people are thinking about for using language models in the clinic. But I think that we should, I always think about what are the risks and benefits for each of those. So things like new visit, patient document identification. So making sure that we have the right documents in front of us. This is kind of probably pretty low risk and potentially beneficial. You could imagine some extraction techniques to make a physician's life easier through summarization. And this is, potentially more risk. There are things like hallucination and missing information, automation bias. Medical record summarization. So this is something, instead of a single document, we're going to take everything, summarize it, so I don't have to read through 40 notes over 10 years. This is not just issues with missing and hallucination, but now you actually get to the point of reasoning what's important and what's not important. And this, again, is more and more kind of risks associated with it, despite having potential better benefit. And then you get into, real medical reasoning, like patient triaging, patient scheduling, which patient should I see first? And, real clinical decision making. So all these are being talked about, potentially all these are being implemented. And as researchers, I think one thing I'm interested in is how do we actually identify what the risks for each of these might be? So this is kind of again a breakdown of all the different ways language models have been at least proposed in use in clinical decision support, or sorry, clinical implementations. Things like decision support, population health, operation support, or prediction of resource requirements. And each of these come with their own kind of risks and rewards of utilization. So this was given all this, I took on this project a couple years ago or a year ago, and it just got published this year. Understanding the implicit bias of language models as it relates to medical data. And so the concern was, this paper from the NYU Lagone was published in Nature about creating a language model that was had generalized use for clinical decision making. And while it was a very impressive paper in a lot of ways, one thing, and I'm glad they had this figure, was looking at its accuracy across different groups. And so this was oh boy. Sorry, I'm sure you guys are all getting the earthquake warnings too. Seems like it's a minor one, but we'll see. So this was a prediction of rehospitalization, and they looked at how well the accuracy of their rehospitalization predictor using this language model across different races. And there's wide variability in their AUC across different groups. And one thing I'll point out is that variability didn't necessarily track with the number of cases they had for that demographics, right? So the white population kind of was middle of the pack, but it had the most by far, right, of 30,000 versus the Chinese population, which was only 2,000. Again, and so the idea is this isn't just a numbers game, right? It's not just, oh, we don't have as many examples for the training set for this. There's also a complexity problem here, right? Where maybe there's a other dimensions that makes it more difficult to predict different groups. And so the bottom line here is looking at performance in aggregate may deceive you in terms of the true performance when it matters in the clinic. And I think that from a conceptual perspective, this is a really interesting problem. I'm going to have to skip through this. We're running short on time. But, the reason this is so challenging in medicine is there are a lot of different features that lead to making an accurate decision and the relationship between that and demographics. So there are biological factors. There are very strong biological factors and genetic factors that we should think about when it comes to determining what the likely diagnosis is or what the right treatment is. So these are things like iron deficiency in people who menstruate, or sickle cell anemia within different demographic groups, or the risk of prostate cancer and the aggressiveness of that prostate cancer in people of African descent. So these are true factors. And honestly, they tend to be the minority of cases, right? They're pretty rare, but they are real. And if you ignore them, that can lead to poor performance in those groups. So that should be included when you're thinking about a model. Those demographic associations should be included. They're non-biological associations. So these are true statistical associations that are present in your data, but maybe have no bearing in biology, right? So higher A1C in type 2 diabetes of patients with African American descent. So this is a true correlation, but this may be due to later diagnosis or poorer access to care, right? HIV prevalence that's correlated with income, or less symptoms in a clinical note in patients who are non-native English speakers. So again, statistical correlations that we will see in our data. The issue is it's unclear whether or not this should actually be in your medical data, like in your model. Like if you bake this into your model, what might that do to your predictions? And so you have both accurate and inaccurate but non-biological associations. And both of these, I think you want to be very careful about when you think about should this be included in your model, in your prediction algorithm. And then you have internal and societal biases, right? So these are things that we think are associations, but may not actually be associations, right? So and they lead to issues within your data. So physician less likely to believe document complaints from a female patient. So the patient may describe something, and then it will be less likely documented by the physician, or prescribing less pain medication to disadvantaged groups, or less clinical and trial enrollment for people of lower socioeconomic statuses. And so, of course, these are things we would want to avoid baking into a model. The challenge is, how do you determine which of these are going on when you have a model that just has different features from the medical records? And so this is not a solution slide, this is a problem slide, right? This is, I think, why it's so challenging, and you can't just blind your model to the demographic groups or other features that you might worry cause bias. So as a kind of starting point, we assessed the potential for bias in GPT-4 in 4 medical domains: intrinsic understanding of the prevalence of disease, diagnostic reasoning, treatment decision-making, and subjective assessments. I am completely out of time. So what we'll say is we saw differences, and these differences did reflect a lot of times how humans, the same biases that you would see in human physicians. So again, not to disparage the language model, but to recognize that this language models might perpetuate biases that we would see human providers make, and we have to be careful about implementing them. And so I always like to think, for each of these, like, what are the risks and where bias could feed in, and which ones might be safer and which ones need to be tested more carefully for bias? And so where's the warning signs when it comes to these clinical implementations, when it comes to equity in the application of language models? And then, of course, right now, companies are not going to be going through these kind of processes, right? So that's where the ethical and moral obligations are on us. And I really appreciate being part of an institution like UCSF that has thought very carefully about how to implement AI models and creating an infrastructure that does it in a safe and equitable way. So model conception and design, and making sure that testing is done across lots of different groups and lots of different subdivisions, testing specificity and sensitivity across each, independent AI governance review board, and then infrastructure that can actually implement. So this is my lab and the collaborators, lots of collaborators, lots of great people. The projects that I presented today, a lot of them were done by Akanksha, led a lot of that work. And then for the bias project, I worked with Emily, who was at MGH at the time and is now a faculty at Stanford. For active projects, we have early detection projects, we have projects around first-line therapy choice, we have projects around toxicity detection, and then projects outside of the oncology sphere, lots of things on medical education and language models, and kind of understanding how AI and medical education interact. Okay, so sorry, 2 minutes for questions. There you go. Looks like I got a question. So I'm going to read this question out. So given insurance can unfortunately play a huge role in determining limiting cancer therapies outside of standard of care, how effectively do you think real-world data and predictive models for precision medicine can be used when someone's health plan gives a denial? Pairing these models with LLM to generate prior auth supporting use. Okay, so give me a second to process. I think this is a very good question. I want to make sure I direct the answer appropriately. So insurance is like our enemy in a lot of ways. I would say oncologists have a lot of enemies: infectious disease doctors, insurance agents, the inpatient staff, but insurance definitely is up there. So we fight, and we don't always succeed in giving a patient the right therapy. Often that's in off-label utilization, right? It's very hard for them to deny standard of care therapies. In that setting, right, to me, it's a little interesting so what is the question, what is the hypothesis? Because in the end, what we're observing is what we actually can get done, right? Not what we would like to get done. And so if we're trying to learn, what are the best treatment options, what we actually are able to get done seems to be the right answer. So yes, we get some denials, but I'm struggling a little bit to understand like how if we understood those denials better, we could improve our understanding of our data. But I have only had 20 seconds to think about it. So I do think that's an important question. I will say, so pairing these models with large language models to generate prior auth supporting use. So prior auth, so Doximity is creating a prior auth creator. I know there's been a lot of public press about ChatGPT being used for prior auth. I'm actually really excited, but I don't know if it was in this class or a different one. Open Evidence, I think gave a talk. So I pushed them, they are very close to doing this. And so I pushed them to do this because, again, as an oncologist, it came up a lot. The real winner, and this is going to be an AI battle, right? Insurance, I'm going to send a prior auth to the insurance agency. They're going to have an AI read it and try and reject it, right? I know this is just going to be like what is a Cold War battle between different AIs, but like you're pointing out, the special weapon would be putting the right evidence in there, right? So not just saying this is what I want, but citing the right trial to show why it's reasonable. And so rather than just an LLM, that LLM has to actually connect to the medical literature and do it in an accurate way. And so that was my pet project I had Open Evidence work on is, yes, sure, prior auth, but I want it connected to the right trial so that when it automatically generates a prior auth letter, it has the New England Journal article that I'm interested in that supports this off-label use. So I do think that there's some promise there. I will say that insurance companies make billions and billions of dollars. And so you can imagine that they have dozens of ML engineers on this task on the other side. So I think it's just going to increasingly get harder and harder to fight them. And I'm not sure I imagine that I will be on the winning side of that, or patients for that matter.
Other questions in the room? Cool.
Yeah, so you mentioned that with like finding the correct therapy for cancer treatments, it takes quite a while, and the percentage of people that bounce around between different therapies and dosages changes quite a lot, right? So the success rate is not too good. Is there a reason it takes so long? Is that like the body sort of acts like a low pass filter and it takes some time for the treatment to set in and you can make that decision? Or is it just due to resources?
So yeah, I don't want to paint too grim a picture, right? When you're on call, not your oncologist, when a oncologist meets a patient, we have standard of care guidelines. And in a lot of times, those standard of care guidelines prescribe a specific direction. However, that is based on a clinical trial that has a very limited patient population selection, right? That's done because pharma companies don't make money from failed trials. So they don't want to enroll patients who are going to have toxicities. So the clinical trial enrollment is, basically, without putting too fine a point on it, wealthy individuals with no comorbidities who are less than 65. And that doesn't very well describe much of our patient population. So when we give that standard of care therapy to a patient, frequently they have other parts, of the substrate that respond poorly to that therapy. And so the challenge is we start with standard of care. It would be unethical in many cases to say, I don't think you're going to do well. So, based on very little evidence, I'm going to give you less than chemotherapy, less than 100%. But then we often have to say, oh, wow, that first cycle, you spent 13 of 14 days in bed. So we can't continue with that, right? So we have to do a dose reduction. And so it's really, I would say, less about a low pass filter and finding a steady state and more just, you don't know, each individual is unique at this point. And you can't know how well they're going to respond to therapy until you try. Now, I'd love to get to a point, the whole point of my research is love to get to a point where we can at least have some probability or prediction of what the right place to start is. so that we don't end up with a month of miserable patient before we come up with the right dosage for toxicity. That's for the toxicity question. For the efficacy question, it's very similar in a lot of ways. The clinical trial, yes, even if you throw away the fact that it's kind of a very narrow subset of patients, it has to make a decision on what it is treating based on very broad criteria, right? I want this mutation, this stage of disease, maybe, having received this first-line therapy. And it doesn't look at any of the other factors that could play into whether this person would respond to treatment. And so in the clinical trial, maybe, a great clinical trial, maybe, 70% of patients respond when the previous group was 65% of patients respond, right? So that means 35% of patients did not receive benefit from that therapy. And so in most cases in cancer, there's a lot of room to understand which of those patients are the 70% and which are the 30%. And we kind of have to do that a lot in real world, well, doing retrospective analysis of clinical trials, but often in real world data, because the numbers are much larger, right? In clinical trial, maybe we have 150, maybe 200 patients if it's a really large trial. We're going to increase that by the order of magnitude just within a few years across a couple different a couple different cancer centers. And so that increases our power to understand which of the variables actually matter for efficacy. Does that help answer the question as to, I don't want to make it sound we're bad at our jobs, right? It's just a tough job.
Yeah, thank you.
Other questions?
I was wondering if you could give sort of, I guess, your opinion on where you see the role of your research and other research being done at UCSF to develop these AI models, whether or not you feel that they're being developed to be more generalizable to other health systems, or whether or not they're just more specific to the UC or even just UCSF patient populations, and you're developing more so protocols and guidances for other health systems to use on their own.
Oh, that's such a great question. I struggle with this a lot. So I kind of see it as a stepwise approach, because one thing I am a little concerned about is the inequities AI creates, not necessarily in accuracy of application, but the ability to apply these models, right? And if I create a model that is perfectly equitable and, has great performance across any individual demographic group, the ability to apply that model might still be localized to UCSF, Sloan Kettering, and Dana-Farber, who has the infrastructure to actually take a patient note, run a language model through a secure pipeline, and spit out an answer in a health system, right? And so those and no way that that's going to be done within the next few years in an oncology center, or even a clinic in rural America, much less somewhere else, and so I do think here my hope in this path is that we create something that works, for example, as a clinical decision support tool to determine what the next best treatment option for an oncology patient here at UCSF is. I think the next possibility for that is UCSF can set up a resource where other centers can submit their patients' data in a HIPAA-compliant way, and we can run our algorithm on that data, even if it's missing individual features, and provide a prediction, again, recognizing that that might be the UCSF population, and it's being run on the decision-making of UCSF physicians, so the retrospective data of UCSF physicians. But creating that kind of portal where it's like you get to make a prediction for your patient, or a clinical decision support tool for your patient from an academic center without actually being connected to the academic center, may be a stepping stone for a way of expanding access to these resources across many different institutions, without requiring the architecture of you know, the GPUs and language models at each individual community site. And without, you know, the other big issue is if we create a proprietary model here, there's intellectual property and concern for patient privacy of releasing that model, you know, in a open way. So that for me, it kind of seems like a middle ground that we could potentially, like, that is achievable, and how I'm thinking about it.
Other questions? Okay. Thanks, Travis, again.
Okay, thanks so much, guys.